Today we will discuss about bronchiectasis. So basically, what is it? It is the abnormal and irreversible dilatation of bronchi or bronchioles. Okay, now coming on to the etiology. Now in etiology, first we will divide them into diffuse bronchiectasis and obstructive. Okay, so in diffuse also further divided into infective and non-infective. So in infective we have bacteria, basically the gram negative, and then we have viral. In viral we have measles, HIV, influenza. Also we have fungal like aspergillosis. Okay. Now in obstructive what we will see is either there will be a foreign body aspiration, that is atelectasis, or there will be a neoplasm, or there will be bronchostenosis, or there can be an extrinsic compression due to enlarged lymph nodes. Okay. In non-infective, what you will see is congenital or acquired alpha 1 antitrypsin deficiency. Now this was also responsible for one more thing. If you remember, it was responsible for COPD, also pneumonia. So cystic fibrosis, Carter Jenner, I think, syndrome. Now in this also we will discuss this later also. Then either it can be due to allergy. Now normally the structure is like this, okay, but what you see is sometimes the structure might be like this, okay, either it can be like this or it might just be this. Okay, so the first one is the cylindrical, varicose, second one, and then saccular. Okay, and this is the normal one. Now coming on to the pathology. In pathology, what we will see is there will be the destruction and inflammatory changes in bronchi, due to which there will be collection of secretions. Then further there will be ulceration, there will be fibrosis, also there will be mucus gland hyperplasia. Now in the non-infective ones I mentioned AIDS. So basically bronchiectasis can mostly occur in immunocompromised patients. Then those who have impaired mucociliary defense, those who have immunoglobulin deficiency, those who have endobronchial obstruction, those who have repeated upper respiratory tract infections, also those who have GERD. Now coming on to the clinical features, first of all I'll just draw someone so that it is easy to remember. I know it's not that pretty a diagram, but yeah, this person is just having a big mouth. So first of all what we will see is we will see chronic cough with massive expectoration, the sweet gas lungs, and now this, yeah, so recurrent pulmonary infections, pleuritic chest pain, dyspnea, pitting edema, then a serious complication is secondary amyloidosis of kidneys. So other features you can mention by yourself like fever, weight loss, anemia, then active sepsis, weakness. Okay. Now coming on to the diagnosis, yeah, in physical signs, you will see some wheezes, crackles, as well. Okay, now coming on to the diagnosis, first of all, since it is the dilatation of the bronchioles, so we will do bronchography for the diagnosis, CT scan, productive cough, purulent sputum, hemolysis. Now in investigation, what you will see is when we do CBC, we will see leukocytosis of PMNL, also raised ESR, then normocytic normochromic anemia. Then we will do the sputum examination, then the urine examination. Then in chest X-ray, what you will see is the lumen will appear to be opaque because of the presence of the secretions in them. Also, a very characteristic feature that you must remember is the tram track appearance. Now, this tram track appearance is also present in one more lesion, which we usually discuss in the cases of general surgery. If you can remember, I'll just tell you. Its significance here. So what we see is these the dilated airways, they become very crowded and they become like a tram track or a ring shadow. So similarly, this keyword is basically also used for CSF rhinorrhea in general surgery, if you remember. Okay, in general surgery, what was it like? There was a formation in which there was blood, because it is having a higher density, so it was in the center and the fluid was in the peripheries. All right, so this was also in CSF rhinorrhea. Then we are done with this. Then there is one more thing you need to remember is the honeycomb effect that will be present. Honeycomb effect. Okay, then you can do bronchoscopy, CT scan, and all. Now coming on to the treatment. In treatment, first of all, what we will do is we will sterilize the sputum. Now for this we need an antibiotic cover. So amoxicillin or ampicillin 500 milligrams 8 hourly. Then oral cefclor 250 milligrams 8 hourly. Okay, if the person is allergic to penicillin, metronidazole. Then we can give bronchodilators. Now bronchodilators like theophylline, salbutamol, and mucolytics. Mucolytics like bromhexine, carbocysteine. Okay, then postural drainage, then bronchoscopic section, and bronchial lavage. Then for the treatment of complications or to prevent complications, what we do is we give oxygen therapy and diuretics. Now surgery is the last modality of treatment, usually when it is not responding to the drugs. Also when there is repeated massive hemolysis. Now coming on to the complications. In complications, cor pulmonale, recurrent pneumonia, then secondary renal amyloidosis, as I mentioned before, then meningitis, bacteremia, septicemia. Now over here, I want you to remember one major investigation over here. It goes on for what we do is to test the ciliary function. As I told in predisposing factors, that the person who has less defense of or less mucociliary clearance. So what we do is we put saccharin, we place it in the nose. Then we measure the time that is taken to reach from the to reach the nasopharynx and to produce the sweet taste of the saccharin. Okay, it is calculated, and then what we see is if the patient is normal, it will be less than 30 minutes, but if it is more, it is prolonged, then we see that there is a ciliary dysfunction, which is cartilaginous syndrome. Okay, so this completes our bronchiectasis. I hope you understood. Thanks for watching.